Hello, my name is Jace, and I'm a critical care nurse practitioner, and today we'll be talking about arterial blood gas interpretation and the approach to the patient with the acid-base disturbance. This skill will not only serve you well in the critical care setting, but the concepts behind it are very important in the acute care setting as well. A perfect example of this is the patient on the floor that is tachypnic. Tachypnea at rest is not normal, so you have to ask yourself, why is my patient tachypnic? Any discussion about acid-base disturbance should start with definitions. What is pH? pH, or the potential of hydrogen ions, is a negative log of the hydrogen ion concentration, which can be very confusing. Basically, it means as the hydrogen ion concentration goes up, pH goes down. The body does a remarkable job at maintaining pH in the body between 7.35 and 7.45. It does this with compensatory mechanisms, and when compensatory mechanisms fail, watch out. So, what is acidemia? Acidemia actually describes the property of the blood, which means the pH of the blood is between 7.35. Note that this is different than acidosis, which is the process we'll go over in a little bit here. Alkalemia is when the pH of the blood is above 7.45. In cases of severe acidemia, cardiovascular collapse can occur. In cases of alkalemia, ventilation could be suppressed, oxygen's affinity may go higher, and there may be cerebral vasoconstriction, which can all decrease oxygen delivery. So it's very important for your body to stay within a normal pH. The carbon dioxide bicarbonate buffer system demonstrates the balancing act the body must maintain for optimal control. The lungs are responsible for removing carbon dioxide, and the kidneys are responsible for producing bicarbonate. Your body produces 16 to 20,000 millimoles of acid a day, so these organs have a lot to keep up with. The key to successfully interpreting ABGs and honing this skill is to have a systematic approach and use it consistently. I begin with determining the primary disturbance. What is the pH? Are they acidemic, alkalemic? If it's within normal range, does it weigh more towards 7.35 or 7.45? Next, let's look at the PaCO2. Is it low, normal, or high? In normal physiology, the brain and lungs maintain tight control of the PaCO2 and are very sensitive to any aberration. Don't believe me? Hold your breath. What would cause the PaCO2 to be high? Well, either an inability for the lungs to remove CO2, like in a primary respiratory acidosis, or the brain just not wanting to remove it, like as a compensation for a very alkalemic state. Next, let's look at the bicarbonate level. Is it low, normal, or high? Bicarbonate binds to the hydrogen ion. Thus, in order to lower the bicarbonate level, it must either be consumed because of an excess amount of hydrogen ions, be lost, like in diarrhea or a renal tubular acidosis, or it maybe fail to be produced altogether, like in renal disease. What would cause an elevation of bicarbonate? Well, if there's no acid to bind to, you're going to have an excess level. So think about the patient who has the NG tube and it's sucking out all this acid. That could be a cause of a metabolic alkalosis. More than one process can happen. In order to determine if it is a single disorder, you should ensure appropriate compensation is occurring. A patient experiencing an acute respiratory acidosis should see an increase in bicarbonate by 1 millimole for each 10 millimeters of mercury above normal the PaCO2 is, plus or minus 3, which is a correction factor. For example, a patient in acute respiratory failure has a pH of 7.21, a PaCO2 of 80, and a bicarbonate level of 31. The recorded PaCO2 is 40 millimeters of mercury above normal, 40. Thus, the expected rise in bicarbonate should be around 4. With the normal range of 22 to 26, the expected increase should be 30. This falls within normal compensation if you take into account the correction factor. There are formulas to determine compensation for each of the acid-base disturbances. In any respiratory disturbance, there are expected compensations for both the acute and chronic state. I will not belabor this, but be aware. MD Calc is very helpful as well. Congratulations! If you have made it this far, it means you can approach a majority of the acid-base disturbances. From this point onward, we will focus on metabolic acidoses, which are common and tricky. In the body, there are cations, or positively charged ions, and anions, which are negatively charged ions. They basically balance each other out. The anion gap is a convenient clinical index that we use to classify metabolic acidoses, as the etiologies differ between a normal anion gap and high anion gap metabolic acidosis. So how do we measure an anion gap? We take the cation concentration, which is just sodium, and subtract it from the anion concentration, which is chloride and bicarbonate. Note, potassium is also a cation, but we don't use it for this calculation. The normal anion gap is between 8 and 16 milliequivalents per liter. A clinical pearl is that there are other anions in the serum in the form of albumin, which are with multiple anionic groups and constitute approximately half of that gap. Thus, a patient with a low albumin level may be masking an elevated anion gap metabolic acidosis. If the albumin level falls 1 gram per liter, then an anion gap will decrease by 0.25 millimoles. The calculation to overcome this is the anion gap plus 0.25 times 40 minus the albumin. There are tons of mnemonics out there for the cause of a high anion gap metabolic acidosis. However, they're only helpful if you can remember them. The mnemonic I use, which is very easy and simplifies this, is the LTKR. Each of these causes increase the anion gap either by accumulation of their organic acids or impaired hydrogen ion excretion. The 4 causes of a normal anion gap metabolic acidosis can be remembered by the ABCD mnemonic. Most of the time, it's our fault. We either gave too much chloride with normal saline or we gave them acetazolamide. However, other causes can be due to loss of bicarbonate, which you can either lose through your GI tract, like in diarrhea and vomiting, or through the kidney. A way to determine if you're losing bicarbonate through your GI tract or your urinary tract is by calculating a urinary anion gap. I'm not going to go too deep into this because then this starts talking about the renal tubular acidoses, but if you're interested in this, there is a podcast episode by the Curbsiders by Dr. Joel Toff who talks about RTAs. Highly recommend it. It's great. So to recap, you now know how to identify a primary acid-base disturbance, determine if compensation is occurring, calculate an anion gap, and list common causes of metabolic acidoses. In the next video, we will go over basic mechanical ventilation. That lecture in combination with this one should provide you with a framework needed for the discussion we're going to have in class. References, links, and the notes will be in the bio. Thanks.